Hello, everyone. Thank you for joining us for the Canadian Cancer Survivorship Research Consortium round today. We have a nice full group here in Toronto at Elixir and a number of people online. My name is Jackie Bender. I'm a scientist here at Elixir in the Department of Supportive Care at the Princess Margaret Cancer Centre. And I will be moderating today for the first 45 minutes, and then I'm going to transition to the speaker today. And I'm really pleased to be able to introduce to you today our speaker, who is Dr. Jennifer Jones. Jennifer is, whom you all know, I'm sure, very well, is Director of Cancer Rehabilitation Survivorship. She is also the Butterfield Drew Chair in Cancer Survivorship Research and a Senior Scientist at the Ontario Cancer Institute here in Toronto at the Princess Margaret Cancer Centre. And she will be talking today about a program that I'm certainly very excited about here. It is the Cancer Rehabilitation and Exercise Program, the CARE program. She's going to be talking about the development and evaluation of this program, which is a multi-component rehabilitation intervention for cancer survivors. And so the discussion format is that Jennifer, the speaker, will present, and then there's going to be discussion in Q&A after she concludes her presentation that will be open to everybody online and in the room. And to contribute online, you can turn your mic on, or you can send us a comment or question through the chat that's embedded within the WebEx platform. So I'm going to pass it over to Jennifer right now.
Great. Thanks so much, Jackie. And Happy New Year to everybody. I'm happy to be presenting for our first rounds this year. I know my title says it's the Cancer Rehabilitation Exercise Care Program, which I am going to be talking about, but what I wanted to do was to start by sort of setting the stage for that and how this whole program came about. So I'm going to give you a little bit of a history lesson on our program, starting from the very beginning. So our program actually started in 2005, and it came about really because survivors themselves were asking for a program like this. And here at Princess Margaret, we had a walk called the Weekend End Breast Cancer, and they raised money every year that went to our foundation, and the foundation went back to the walkers and asked, what kind of things do you want us to spend the money that you raised on? And one of the things that they came out with, obviously, clinical care and research and support and education, but one of the things that came out was they wanted a survivorship program. And because of that, the foundation gave us some money to start our program. And to start, we opened up a lymphedema program because that was sort of the biggest need. And remember, this was just with breast cancer survivors, so it was in the breast site, and it was limited to the breast site at that time. But over the next couple of years, our program expanded to include also gynecology because that walk that I was telling you about expanded to the weekend end from the weekend end breast cancer to the weekend end women's cancer. So our mandate and funding changed to women's cancers. And then head and neck also joined in on the fun with because they had given us a bit of money. So this is sort of the way we functioned for the next 10 or so years, where we had, as you can see, there's these different columns, and we had individual clinics that we ran, so patients could be referred directly to one of these different clinics: lymphedema, functional mobility, fatigue, neurocognitive. And in addition to that, we also had something called the Survivorship Consult, which was offered to people at the beginning. Really, we tried to get them referred at the very beginning of their diagnosis and their cancer journey. And it was they would sit down with a social worker and sort of talk about their goals and get an orientation to different services within the hospital. And the consult actually took up like a good portion of the patients that were coming into our program were getting that survivorship consult. So I actually came in and was working with the team and sort of took over leadership in 2014 after the death of our leader, Pam Patton. And so at the time, there were a lot of things sort of environmentally and within the hospital changing that started to make us think about how we were delivering care and how maybe we wanted to change it moving forward and how we wanted to evolve and really expand. And there was a couple of reasons why we wanted to do this. So first of all, the way that we were running with these sort of siloed clinics didn't really allow for interdisciplinary comprehensive assessment and sort of comprehensive care plans for patients. So for example, a patient would be referred to, say, our fatigue clinic. They would come into the fatigue clinic. They get assessed at the fatigue clinic by, say, an occupational therapist, go through that. And then during the process of that, it might have been identified that they also had a neurocognitive issue that they could benefit from that clinic, so they would get referred to that clinic. Then they would see the neuropsychologist there, have an assessment. So as you can see, there were lots of different assessments happening, and the team, which was very inter and multidisciplinary, wasn't really, talking about a comprehensive plan for that patient. So as a result, the model really wasn't patient-centric. There were multiple visits for patients on different days, resulting in higher costs for our patients themselves and also for us, and really wasn't coordinated for the patients. And in the end, really the model, when we started looking at the increased volume of patients that we were seeing, it really wasn't a sustainable model. So we were starting to see expanding referral sources. Every year our numbers were going up. Our funding was staying pretty much the same as was our team size. So as a result, we were seeing a lot longer wait lists, and we felt like there was a need to start focusing on patients who really needed our specialized service. We have a very specialized, highly trained team, and so really trying to figure out what patients need our services. And we also felt like there were lots of great programs out in the community already. So Wellspring, Gilda's Clubs, different programs like that had lots of education and support programs available to patients. And we felt like we weren't really coordinating well with them in terms of getting patients actually into their doors. So we felt we needed to better coordinate with existing programs, also programs within UHN, to avoid any sort of duplication of services and to connect patients with the most appropriate and accessible services to them. And finally, at that time, we were still only seeing primarily patients from the breast, gynae, and head and neck site. And so the model was not inclusive of all sites at Princess Margaret. And there were more and more people sort of coming to us and saying, oh, we'd really love to be able to send our GI patient to you, or whatever. All the different sites where, we had patients that were interested and clinicians that were interested. And our funding had actually changed by that point, so that we were getting funding from a whole bunch of different sources within the foundation. So our mandate really changed to be able to expand our services to all the sites at Princess Margaret. But in order to do that, we had to sort of figure out how we were going to do that. Obviously, to open up to the whole hospital and to sort of change all of that care, we had to start thinking about what our model of care was going to look like. And I guess, this was written by Julia Rowland, but, the fundamental question for cancer survivorship is, what should the optimal care look by? Who should care be delivered by? In what setting? What guidelines? And what are the best practices? And at that time, when Dr. Rowland wrote this, there wasn't really a lot out there. But more and more, we're seeing literature coming out helping us to inform what this care should look like. And I'm sure you've all seen sort of this sort of supportive care triangle, or this triage type of care. So the idea of we have it at the top of that you could invert this triangle, but here, the majority of people really just sort of need self-care with support and, patient education. For the most part, they do quite fine. There's the group in the middle that may need some more shared care model, and then there's the very complex at the top. So we were just starting to look at different models of care for our patients and what we were going to look like. And at the same time, there were articles that were starting to come out, this one from Catherine Alfino that many of you I'm sure know, really starting to talk about the role of cancer rehabilitation and its role in cancer survivorship. Now, cancer rehabilitation had sort of actually has been around for many decades, and in the 70s there was a lot of energy and enthusiasm, interest in cancer rehabilitation, but it never really got the momentum that it probably deserved and needed at that time. But in the last decade or so, it's sort of come back, and there's been a lot of interest in it. And this is a great paper. I actually really recommend people looking at it, about just how cancer rehabilitation plays an important role in terms of cancer survivorship. And at the same time as well, with that more focus on cancer rehabilitation, there was different guidelines that were starting to come out. So we saw the American College of Sports Medicine coming out with guidelines for exercise for cancer survivors, recommendations coming out from many different societies. And as well, there were also lots of different articles, and evidence base was growing and growing in terms of the benefits of exercise and physical activity with cancer survivors, showing benefits in a whole host of different outcomes that are sort of listed here on the bottom of the slide. So this was sort of the atmosphere. And at the same time for us internally, in 2010, we received an infrastructure grant through CFI that allowed us to build a survivorship center. And really for us, this center really helped us to be able to expand what we were delivering because it provided us with gym space, a teaching kitchen, space for meetings, space for delivering some innovative programs for cancer survivors. So with all of that sort of environment in place at that time, we, in 2014, decided that we were going to do things a new way and build a multi-dimensional cancer rehabilitation program here. And our mandate was to expand to all sites of Princess Margaret, target those patients who needed our services the very most with more of a focus now on cancer-related impairments, and as a result, eliminating those survivorship consults that we were doing because we felt like patients were able to get that support that they needed through our oncology education program and through our community programs. We need to more formally integrate with community programs and also within programs within UHN. So at 2010 or 2011, a year after Elixir opened, TRI, which is the Toronto Rehabilitation Institute, formally joined with UHN, which is our hospital group, which allowed us really to have access to more rehabilitation services. And then we also expanded our team. So we had the mandate to expand our team, given the now the focus on cancer rehabilitation and as well the growing body of evidence that physical activity, exercise was important for cancer survivors. We added physiatry to our team, which allowed us to increase the complexity of the patients that we can see and streamline care, and also kinesiology with Daniel Saint-Amina coming. So Daniel Saint-Amina had built a program within the prostate site for exercise, cancer exercise, and we sort of adopted that program and worked with him to roll that out here within our program. In order to do this, our mandate was to focus on group-based models, so delivering more and more group programming as opposed to one-on-one in order to have more sustainability, but also because we know groups build support networks for patients, and also leveraging our infrastructure. So there was a big, long, and I won't go into the details of this, you have them in the slides, but basically there was a 2-year implementation process that included lots and lots of different things. So for example, I mean, you don't really think about all the little things that have to be done when you roll out a whole new program. But it was, just starting with looking at our human resources and aligning with all the different initiatives at the hospital and within the community. And, adding the new staff and training the new staff, developing new referral forms, developing a brand new assessment, decision algorithms for treatment, and then developing what the actual programming that we're going to offer looks like. So developing, which I'm going to explain to you in a few minutes, integrating with different programs and referral processes, formalizing referral processes out to the community, developing all the supporting patient education materials, and then developing sort of an evaluation framework. And then, so we did all that, and then in 2017, so starting sort of at the end of 2016, we piloted our new model of care, finalized pathways, got feedback from patients. We're always continuing to innovate. Our program is never static, so it's always changing, and we're always sort of getting feedback from people and collecting data. but we were refining at this point really what our final model of care was going to look like. And at the same time of doing all of this, obviously it was really important for us to look at what other people were doing and learning from other programs. So we did an external scan of different programs and visited different programs. You know, obviously one of the leaders here in Canada was Martin Chason's program that started at McGill and then was in Ottawa, and now he's running it in Brampton. There were other programs around Siegel's in Ottawa, and then over in Scandinavia, they're quite a lot further ahead than we are in some parts of Europe in terms of cancer rehabilitation, and there were some really nice sort of guidelines and process flow maps that we could use that we can model after. So while we were doing this, we thought it would be really important to talk to patients about what it is that they would want if we were going to develop a group rehabilitation model and how that should be structured and what topics they would want to learn about. And when we talk about a group rehab model, we had decided based on the literature review that we didn't want to just do an exercise program. We felt we wanted to do a multi-component program because that's where the evidence showed the sort of the best benefit. Pairing exercise along with self-management and skills building. So we did a survey of patients coming into our program. It was a quick survey, just over a couple of months with just under 60 patients that came through our program. And, you know, this is just what it looked like. So you can see at the time, we were still really primarily seeing breast patients in our clinic, a nice distribution. Mostly patients were sort of 60 plus or 40 to 60, and a distribution of patients either who were still on treatment, had finished treatment in the first year, or were more than 1 year post-treatment. And we asked them, would you attend a cancer rehabilitation program that was offered here at Elixir, that was delivered in a group setting, that was offered weekly, and could include maybe exercise, education, and goal setting? And 65% of people said, yeah, they would be interested in that. So we asked them about what the length of program, length of session, and the contents of the session, and got feedback on that. So the preferred length was an 8-week program, which aligned very nicely with the literature that was out there that showed that that's, you know, a beneficial length. People said about an hour would be good for them. Interestingly, you know, there was like the wide range, but the majority, 40% was like the one that was most popular. It's interesting though, because we have ended up actually with a more than over 2-hour session, and it's actually because the patients themselves wanted it a little bit longer once we started rolling it out. And people were interested in education, also exercise, and some people were interested in all three. Oh, sorry. And then we asked them, in order to inform the classes, the self-management classes that we were going to provide, we asked them about, you know, to rate we had a whole list of topics, and they could also add topics if they wanted, and they listed which ones they ranked, which ones they thought were most important. So none of these were really surprising to us. Managing energy, exercise safety, diet, nutrition, brain health, relaxation, so all of these different things. And then we took that, and that helped to inform the content of our program. So in 2016, as I said, we started piloting. We did a sort of formal launch of our new program, which used to be called the Cancer Survivorship Program, and we renamed it the Cancer Rehabilitation and Survivorship Program. We were fully integrated with TRI. We had developed new referral forms integrated with clinical DART, which is our distress screening here at Princess Margaret. Figured out a way to do intake screening through EPR and the referral forms. Developed a comprehensive interdisciplinary assessment of patients as they came in. Developed new triage criteria, patient flow process map. Introduced a structured group rehabilitation program, which is called the CARE program, which I'll talk to you about. Formal referral to community partners, and developed a longitudinal evaluation plan. So all of this was sort of ready to go, and I'm going to describe each sort of component to you and what the end sort of program looked like, so you can understand it. So this is what our clinical team looked like after. So since 2000 and probably earlier than 2016, really, this is what our team looked like as we started to build it. So as you can see, we added physiatry and kinesiology to our team. We have physiotherapy, massage therapy, nutrition, neuropsychology, occupational therapy, social work. So this is our team. We have, this is the referral form. This probably is an old one. We change it all the time. But the referral form, basically oncologists within the clinics can identify the need for a patient to come to our program, fill out the referral form, and send it to us. We then scan and review the referral form, look in the EPR to ensure that it's an appropriate referral. And this is basically what the process flow looks like now. So the referral comes in, it's screened. If the patient's eligible, then they come in to receive a comprehensive assessment. So no longer do we have those siloed sort of clinics anymore. They come in and they have one comprehensive assessment with our team. And the assessment can be done by physio, OT, and physiatry. And even if a patient is referred to us, say, for fatigue or for like a functional issue, we do a very comprehensive assessment looking at all of these different outcomes. And the assessment takes sort of on average, about an hour and a half for patients. It depends on the complexity. And based on the outcome, we develop goals with the patient and a comprehensive care plan based on that assessment. And from there, patients are sort of triaged to different sort of, I guess, plans. So in some cases, patients have quite mild impairment. It's not very complex. And in that case, and we don't see a lot of these patients because most of the referrals we're getting are pretty appropriate. But in that case, we can really just refer patients out to the community, to programs within our hospital, and sort of send them on their way. In the most cases, patients come into our program, which is the CRS program here, and I'll describe what we offer within our program. In some cases, we identify that there's something that needs more one-on-one manual therapy, or they need to be stabilized for some reason before they come into our program. So an example may be, say, a patient comes to us and has a high level of pain. And so for that, in that case, really their pain is probably the primary thing that needs to get addressed before they can go through a rehab program. So that would be an example of like patient then may get referred to a pain program or may see physiatry for their pain and get that managed. And then they would come into our program. So this is just an what sort of the comprehensive assessment looks like. And so, as I said, for patients that were referred and it looks like it's sort of more high to moderate complexity, they're booked in, they're referred to as C1 or C2, they're booked in to have a 1.5 hour assessment with physiatry is always involved with these cases, and then as well OT or PT. And for patients that have more low complexity, they're booked in for a 1 hour assessment. And as I said, we measure all of these different aspects of their functioning. These are just the referral forms that I've thrown everything in this presentation, I see. These are the referral forms we developed. Actually, I thought this was really great. We have lots of partnerships within the community, and we developed a really nice sort of a list of all the different community programs that we could refer patients to, and then sort of now have a more formalized referral process. So patients would be formally referred to these programs. So the patients that come into our program, the goal for our patients that come in is that they come in for a limited amount of time. They're not coming to see us for years and years. Really, we're just trying to have them come, get stabilized, get back on their feet, and get well enough to then get back into the community and potentially hooked up with those community-based programs. So often when people finish with our program, then we do that referral to those community-based programs to continue on with all the great work that they're doing. So the patients that come onto our program may have one of these consults added into their care plan. So we do offer a lymphedema program that is both group and one-on-one appointments. We have physiatry follow-up, physical therapy follow-up, return to work and school consults, social work consults, nutrition consults, sexual health consults, and neurocognitive consults. And the reason why these are not offered in a group format is because they really don't lend themselves as well to sort of group format. And they are very individualized. So for that reason, we have kept these as one-on-one appointments, but they are limited. In most cases, patients only need 1 or 2 appointments, and they're fine to get on their way. The sort of meat and potatoes of our program is called our CARE program, which is what I want to focus on for the remainder of my presentation. So this is a group-based program. The goal is to support lasting lifestyle changes in order to manage the effects of cancer. Lots of our patients come in with a number of different issues, and we know that exercise can, and all the education that we can provide to them over the course of this can help to address sort of these clustering of symptoms or a number of different complexities. Patients come, so they'll, after their assessment with their initial assessment, they'll come and have an individual fitness assessment with our kinesiology team, and based on that, have a personalized exercise prescription developed for them. And then they come into the 8-week program, and the 8-week program consists of a weekly exercise class followed by the skills self-management patient education class. So you can just see the topics that are covered each week. They go through the 8 weeks, and then after the 8 weeks, they come back to us at 3 months and 6 months. We do a follow-up assessment with kinesiologists. We'll see them again and do another fitness assessment, check in to see how they're doing with their exercise, maybe adjust their exercise prescription for them, and screen for any issues and any problems. If there's any other problems, then they may come back and see our team, but otherwise they are supported and sort of sent back to continue on with their exercise program at home. So we started to sort of look at initial process outcomes. So in that sort of pilot period that where we first were piloting this new model of care, there were a lot of things that we saw right away. So for example, right away, before we initiated this new model of care, our wait list for into the different clinics was around 8 weeks. And right away, we were able to reduce that to 1 or 2 weeks. And really, part of that was because a lot of our time was taken up with consults and with all these individual assessments. And so we were able to increase capacity. And another thing we saw was that we, over the first year, we increased referrals to our community partners by 72%, which was really great. Now, this chart here just shows you, these are the number of new patients seen from 2010. So this was the old model up to 2016. So the red line is actually the consults, and you'll see that as soon as we eliminated the consult, the blue line goes way up, and this is really new patients for specific cancer-related impairments. So it really just freed up our ability to see more and more patients that had cancer-related impairments. So over the past 3 years, since we've initiated this new model of care, we've had an average increase of about 29% new patients entering our program each year. We now see about 90 to 110 new patients every month from across all disease sites of Princess Margaret, and we have about 1,000 follow-up appointments a year. Physiatry visits have increased dramatically with the addition of Dr. Chang, and also we now have a fellow. We've rolled out a fellowship program here. And as a result of this, it really does help to reduce oncologist appointments, because often what was happening before is, for example, if a patient was referred to us for lymphedema and they needed to have some testing done, we'd have to ask the patient to go back to either their family doctor or their oncologist to get those tests ordered. But now we don't have to do that. Now they can have that all ordered within our clinic. And I do want to mention, though, that the complexity of the patients that we've seen has really changed. So patients are much more complex. It is much more of an impairment-driven program. So these are just new patient referrals that were approved, and this just shows 2017 and 18. So we just finished our statistics for this year, and we were just under 1,200 new patients this year. So the volumes are just increasing. And this just shows the distribution of patients that we're seeing. So there is still a lot of breast patients, but you can see all the different colors. So we are starting to see some success in the program rolling out to all the sites at the hospital. And in terms of the primary reason why patients are referred to our program, musculoskeletal, first lymphedema, exercise and deconditioning, fatigue, neurocognitive. So those are our primary ones. There isn't too much of a wait now, but when patients are waiting to either come into the comprehensive or waiting to get into the, Stephanie, remind me, is it before the comprehensive or is it, yeah. So if they're waiting for a couple weeks before their comprehensive assessment, for example, if we know that they're getting referred to us for lymphedema, we would send them to the lymphedema management class. So there's classes available that we can right away refer patients to while they're waiting for us, and it really helps to, actually, in a way, it's a stepped care model, and because for some cases, they might go to that class and realize, that's all I needed. I'm doing great, and I don't need to come, so it allows us then to sort of screen out patients that don't need our services, but also identify patients that do. So at the same time, we've also developed an evaluation framework around the CARE program, which is our 8-week program. So we use the Institute of Health Improvement Triple Aim Evaluation Framework for this, and looking at a number of different outcomes. So patients, as I said, they have that initial evaluation with the kinesiologist, which is our baseline assessment. Then they have an assessment again at the end of the 8-week program at 3 months and 6 months. And each of these time points, we collect a number of different physiological outcomes like heart rate, blood pressure, balance, a whole bunch of things. We also ask patients to fill out a number of patient-reported outcomes, looking at disability, social functioning, distress. We've also been collecting patient satisfaction surveys as well, and monitoring like our wait times, making sure that people have access to the program. So these results that I'm going to, so before I get to the results that I'm going to present to you are really, really preliminary because I haven't gone through them with the biostats team yet, and we're still sort of cleaning the database, and we're continuing to collect data. But I did want to show you some initial data, just because I think it's interesting, and it was interesting for me to start looking at it a little bit. So our primary outcome of our program is actually disability, which we're measuring with the WHO Disability Assessment Schedule. And so this is looking at data of patients over the 3 time points. So time 1 is baseline, time 2 is at the 8-week, and time 3 is 3 months. We don't really have enough data at 6 months yet to be able to present that. So this is small, but what you'll see is that here are the means, is that we are seeing a nice decrease in terms of disability. You want disability scores to go down, obviously. So we are seeing that trend of the disability scores going down over the time and continuing to go after the 8-week, which is great. Now, there is a cutoff on the HUDAS for moderate and severe disability. And so what I would have liked to see this drop a little bit more, but what we do see, so this is, green line is baseline and the blue line is time 2. I haven't showed the time 3 yet, but what we're seeing is at baseline, this is actually really shows you how disabled and impaired these patients are coming in. At 90% are either at moderate or severe disability on the HUDAS, and that goes down to 85% by week 8. We see some great things in terms of physical activity. So we ask patients to report on their physical activity using the GODIN, which I'm sure everybody's pretty familiar with. So we are seeing patients reporting many more more minutes per week. And then here they come in at their assessments, they do the 6-minute walk test, which is maybe a little bit more objective. It allows us to really see their fitness level. And we are seeing a significant change from baseline to 8 weeks. And this is actually a clinically meaningful difference on the 6-minute walk test. And that seems to be maintained 2 to 3 months. In terms of heart rate and grip strength, we're seeing trends going down for heart rate, and for grip strength, not as, it was improving a little bit at 8 weeks, but goes back down. Now, for the patient-reported outcomes, in terms of mood, we see a decrease in terms of depression scores, and anxiety stays relatively the same. For social functioning, we measure this with the social difficulties inventory. So there's a total score. A cut score of 10 would be somebody who has a high level of social difficulty. So at baseline, the mean score for the groups was over that cut, but you see it decreases a little bit by 8 and 3 months. But the SDI has actually 3 subscales. So there's the everyday living, there's money, financial issues, and then there's sort of like self-care. And I've just shown the everyday living one, which does significantly decrease. Where we didn't see changes was in the financial one, which kind of makes sense, and we don't really target that in our intervention. We also ask patients about to provide feedback, patients' satisfaction, and getting their feedback on the program. So we ask patients, were you happy that you participated in the program? Did you find the atmosphere supportive and encouraging? And would you recommend this program to other people? And as you can see, most patients either agreed or strongly agreed to these statements. And these are just a few quotes from patients who come through our program. An excellent, fulsome course. I found lessened anxiety by joining the group. The sharing experience. The instructors and counselors helped tremendously, physically and psychologically. This course should be an extension of most everyone's cancer treatment plan. Shows you that you're not alone and helps with questions, feelings that you are experiencing. So that's the program, and as this is very preliminary data, and I'm hoping in the next year we'll have a lot more that will be coming out, and we'll be presenting and publishing on that. But I did want to sort of really more focus on sort of how we actually developed the program and the evolution of it. And we always, as I said, our program's always changing. So we do have plans to sort of build on this CARE program. So the first one is to actually develop a virtual care program at home. So right now we actually do have an at-home exercise program, but our goal is to actually roll out what we're delivering in person to at home. So really including those classes and all the support you would get as if you were to come in person, to be able to deliver that to people at home. And the reason why we're doing this is because we found, about 40 to 50% of the patients that come to our program that would benefit from our 8-week care program are just unable to come to a weekly group program because of where they live or whatever barriers they may encounter. And so because of that, over the past, it's been, I guess, over a year now, a year and a half, we've been trying to translate our in-person program to an online virtual program. And I'm very happy to say that this will be launched in February. So the program includes a number of really beautiful online modules that patients would go through each week. We also have an app called PhysiTrack that some of you might be familiar with. We didn't develop this. This is an app that's available for use that physiotherapists use often. It actually has hundreds of different exercises and videos of exercises, so we're able to sort of prescribe in the exercises. Kinesiologists can prescribe in the exercises, and then patients can open it on their phone and watch the videos, so that helps to support them doing their exercises at home, since we won't be supervising them every week. And as well, we're also including Fitbits in this. So the patients going through this program will also all get a Fitbit. We'll be able to monitor them from remotely, so that we can see what they're doing each week. And then they'll get a phone call, or either a phone call, email, or text, depending on what the patient prefers, each week with our clinical team, sort of checking in with them to see how they're doing. And when they call in, they'll be able to see, did they finish their module? what's their Fitbit data looking like? Have they done their exercises on their PhysiTrack? So it's a way for us to remotely monitor them and connect with them so they don't feel like they're just sort of sent off for 8 weeks and asked to do this on their own. This is a really busy slide, but I just wanted to show you that in the first steps of this actual development of those modules, we actually did a bunch of user testing on the modules and different aspects of the modules, and we worked really closely. This is a partnership with the oncology education team. So not to go through all of this, but just to let you know that we have done a lot in terms of making sure that those learning modules are patient-friendly, easy to use. It really make sure that the message comes through very clearly to patients, and that they won't get frustrated by the technology or not understand buttons or how to use things. The other initiative that we're doing is we're extending our program to patients with advanced cancer. So we were seeing more and more patients getting actually referred to our program that had advanced cancer, and they were just coming through our regular care program or having one-on-one consults. But as the trend here at Princess Margaret, and I expect it's the same at other centers in North America, is the trend is now, and I think recommendation is now to start referring patients much earlier on to palliative care programs. Here at our hospital, there's a big push to refer patients early to the palliative care program. But often patients, when they get referred early on, they're doing quite well. There's not really much to offer them at that point. And at that point, a cancer rehabilitation program might be actually a great time to offer that. In a way, it's almost like a prehab type of model for patients with advanced cancer, because they're not necessarily too symptomatic at that point. So our goal was to work with the palliative care team and also be able to offer patients who are already getting referred to our program a specific care program specifically for patients that have advanced cancer. And so in order to do that, this summer we did a survey. We went into the palliative care clinic and did a survey over a month with 60 patients just to look at their interest in this type of program and priorities for program structure and content, very similar to what we had done when we initially developed CARE. And we found that 57% indicated interest in a cancer rehabilitation program. So I'm just going to show you some of the data here. So so we decided that the inclusion criteria are patients that are at least 6 months prognosis or greater. They have to be English speaking. This is just the survey content. So we asked about demographics, their willingness to participate, program format, priorities for physical activity, education topic preferences. And as I said, we collected 63 with 56 complete. So there was the interest in the program. The reason why those people who weren't interested, some people said it was too far, which can be addressed maybe with our Care at Home program if we adapt it for advanced cancer too. Some people said no time, parking is always an issue here, not interested or other reasons, and for that some people just said, some people said there's no point if cancer is incurable, or they weren't feeling well enough. And when we asked them, well, would you be interested in something delivered at home? Just under 60% said they would prefer if they could do it at home. The most important topic for them was pain management, fatigue, energy, attention, concentration, memory, diet, nutrition, and improving sleep quality. And they were interested in sort of a 4 or 8 week program with 1 to 2 hour sessions, 1 time a week, which works out well, so that's sort of what we're doing. So that's what we're going to be now piloting. We have a physiatry fellow, David Langelaire, who's here with us, and he is really interested in bone mets and advanced cancer and cancer rehabilitation, and he is piloting this as part of his fellowship program here. And this will be rolled out. We're starting recruitment next week, and hopefully we'll be running our first 2 groups starting in the end of February. So finally, I just wanted to finish because the other thing that we realized when we've really looked at sort of how well we're doing with our CARE program is we decided that we really wanted to really spend a bit more time focusing on the behavior change aspect, which any of the people on the phone who do any sort of lifestyle interventions know that's sort of the key. And I think we were already doing a good job, but we really decided that we wanted to focus more on that because we felt like sometimes the patients coming into our 8-week program, they'd come to the classes, but then when we're asking them to do their exercises back at home, they weren't really doing that. And so how do we motivate people to do that? And also once the 8 weeks over, continue to engage in the behaviors that we're trying to get them to do. So we're primarily using a motivational counseling approach. We've hired a motivational interviewing trainer, and every single person on our team is going through motivational interviewing training, which many people on the team have already had before and are actually quite good at it, but it's always great to continue working on those skills. And we've also done an audit of all of our slides, all of our modules, everything that is patient-facing, to make sure that the wording is really adherent to motivational interviewing counseling approaches. So really trying to push that behavior change. We're also hoping to add in Fitbits for our Care at Elixir group too, because they are in between classes. They are supposed to be exercising at home, so we hope that that will help them to motivate them. So lots of different things we're trying to do there. So I'm going to just finish by thanking our amazing team. And we have a big team and research and clinicians that are have been involved in the development of the CARE and CRS program. And I want to thank everybody who's a part of that. And thank you. So